Good morning. My name is Tracy Wright. I am delighted to welcome you. I am delighted to welcome you to the inaugural virtual rheumatology practicum for pediatrics. I am on faculty at UT Southwestern here in Dallas, Texas, and I'm also a member of the ACR Committee on Training and Workforce. And we are really excited to have the opportunity to share this lecture series with you. I wanted to extend a very special welcome to the first year Pediatric Rheumatology Fellows. We are really delighted to have you join our community, and we hope that this lecture series will really be a strong foundation for you as you begin this lifelong journey of learning. I also wanted to just extend a special thank you to the work group who helped to organize the lectures, and a special heartfelt appreciation to both Connie Herndon and Robin Campbell, who are the ACR staff whose hard work has just been critical for the launch of this program. And next, I would like to introduce my co-moderator, Elizabeth Sloan, and she will provide some of the ground rules for attendee participation.
Hi, everyone. I'm Elizabeth Sloan, and I am the third-year fellow at UT Southwestern. And I'm also on the ACR Fellow in Training Subcommittee. And we're going to go over some ground rules real quick. So all attendees will be muted throughout the webinar. And Tracy and I will be monitoring questions, and we'll present them to the lecturer at the end of the presentation. You'll see that there are 3 options at the bottom of your screen for comments and questions. The chat function can be used to make general comments that everybody can see. If you need to get the host's attention, you can use the raise your hand function, and the host will chat with you privately. And then the Q&A will be how you post questions that are relevant to the lecture. And only Tracy, myself, and the lecturer can see these questions. And we will use those questions at the end of the session.
So it is now my privilege to introduce our speaker for today. So Dr. Brent Graham will be giving our initial lecture. He graduated from Vanderbilt University School of Medicine and then completed his residency training at the Children's Hospital of Philadelphia. He then went on to complete his fellowship training at Cincinnati Children's Hospital Medical Center. And after serving on the faculty in Cincinnati for 10 years, he then returned to Vanderbilt in 2008 to become the division director for the Pediatric Rheumatology Division there. So we look forward to hearing Dr. Graham's lecture today entitled Approach to Musculoskeletal Pain. Thank you, Dr. Graham.
Thank you. I want to thank Robin and Connie, Tracy and Elizabeth, and all who have worked on this. I think we're all learning in different aspects of our professional and personal lives. There's some good things to come out of the pandemic, and this seems like one that hopefully will be good for fellow training into the future after the pandemic, and hopefully we'll keep getting better at this. I have no disclosures. So we're going to talk about musculoskeletal pain, and we're going to talk about a framework. All of us see this a lot in our clinic, and some of these patients end up having rheumatic diseases, and some have other diseases. I still enjoy all these different types of rheumatic of joint pain and different presentations. Some find that tedious, but I think that I enjoy it, and it's definitely going to be a big part of your practice and an important part of your practice, because we need to also help make important diagnoses, including infection and malignancy, and even mechanical and orthopedic things. So we're going to talk first. When you have a patient present with musculoskeletal pain, it's very important to focus especially on in toddlers, is this really a joint issue, or is it any other part that can affect the musculoskeletal system or the limbs? And so history is important, exam is important, just having a broad process of thinking about things. So in the skin, patients can have vasculitis that causes musculoskeletal pain. It's particularly entities like HSP, where they get edema, but it's painful. Paniculitis, erythema nodosum is the most common. That's obviously easy to see with the rash. We need to think about the muscle myositis. Some patients will present to our clinic with congenital myopathies, where we are the first line in making that diagnosis. We need to think about bone pain. Often osteomyelitis is adjacent to the joint. And then nerve pain. Nerve pain includes nerve lesions, damage to nerves. It also includes amplified musculoskeletal pain, which is a pain processing issue. They will often present to our clinic as well. So I want you all to write this down or take a picture. You'll probably take a picture. We're going to think about categorizing different types of joint pain in terms of their underlying etiology. So those categories are infectious, post-infectious, mechanical, autoimmune, and neoplastic. And I had an ER mentor who told me everything should be 5 categories. So we throw some things into mechanical that are a little bit of a reach, but to keep it at 5 categories, that's helpful. As we go through our schematic for thinking about this, I want you to, we'll talk about, and I'll ask you to try to determine which is going to be the most likely in each category. Okay, so we're going to divide joint pain into monoarticular or polyarticular, with or without the presence of arthritis. And arthritis in patients with known JIA is defined as swelling, or in the absence of swelling, limitation of motion accompanied by pain with motion, tenderness, or warmth. And for the purposes of this talk, we're going to use the same definition, although some patients will have limitation of motion and pain with motion and have causes that are not arthritis. When the patient is presenting to your clinic, we don't typically have immediately joint fluid or synovial biopsy as a way to confirm histologic arthritis. So monoarticular arthritis, I want you to think about our categories. When a patient has a monoarticular arthritis, what are the most common causes amongst infectious, post-infectious, autoimmune, mechanical, and neoplastic? Okay, so infectious, autoimmune, and mechanical are the most likely. Much less likely are post-infectious and neoplastic for monoarticular with arthritis. So we're going to talk about, throughout the talk, what are the historical features that help you differentiate infectious versus autoimmune. Acuity and duration of symptoms is a big one. And really, when you have a patient present with one joint, those are going to be your most likely etiologies. So autoimmune is JIA. There's some other entities, but for the most part, when you see a kid in your clinic with one joint, this autoimmune JIA is going to be the diagnosis. So oligoarticular is about half of patients with JIA. Monoarticular presentation is about half of those, so 20 to 25% are monoarticular presentation. Knee is by far the most common, especially in young kids, young girls who have that oligoarticular early onset subtype. With monoarticular, typically the most important is to rule out an infectious cause. We think about bacterial. Obviously, that's important, and you guys have done that in your residency. Acuity is important, but there are some patients who will present a little bit more indolently with an infectious arthritis. Kingella kingii is one of those. So in a monoarticular joint, nobody's going to fault you for aspirating the joint and getting fluid, but we also look for other evidence of infection. We look for things that point towards duration. In teenage patients, gonococcal arthritis can present as a monoarthritis. Gonococcal arthritis has sort of two forms. One is an early bacteremic form in which the patients are febrile. You could grow it out of the blood. They have predominantly a tenosynovial presentation with distal joints infected, fingers, feet, may have an arthritis during that time, a vasculitic rash as well. So that's a relatively acute presentation, but later in the course of disseminated gonococcal infection, it can settle into one large joint. The patients may not be febrile, and you grow it out of the joint. So having a low threshold for thinking about that in teenagers is important. Lyme arthritis is the one that can most closely mimic JIA. We don't see a whole lot of this in Tennessee, although we're starting to see a little bit. But Lyme arthritis is predominantly knee. They can get a very inflammatory arthritis. Historical history is very important with that, including travel history and exposure history. Mechanical hemarthrosis is the one that can present with fluid in the joint. So aspiration can help you with that one as well. Post-infectious is typically polyarticular, but it's important to recognize that post-infectious arthritis can be very sensitive to NSAIDs, which is good in terms of pain relief, but can be bad in terms of helping you understand etiology. So if a patient is started on NSAIDs for a one joint arthritis fairly quickly and has a great response, it could be post-infectious, and you may be inhibiting their migration by the use of NSAIDs. History is important, but it's also important to recognize that at least a third of patients with post-streptococcal arthritis or rheumatic fever will not have historical evidence of an antecedent strep by history. Neoplastic with monoarthritis, we think of some benign tumors. Synovial chondromatosis is one that will eventually, it can cause fluid in the joint, will eventually cause calcifications that will show up on X-ray. Tenosynovial giant cell tumor is the new name for what used to be called pigmented villonodular synovitis. This is a benign tumor. It's predominantly large joint, but it can be small joints, including tenosynovial. Knee is the most common. These patients have a giant cell tumor of their synovium that results in recurrent joint bleeds. And you need to think about this when you get a bloody fluid or when you get a very proliferative synovium. MRI can be helpful in showing hemosiderin deposition as well as synovial biopsy. So monoarticular no arthritis. I want you to think about categories for that as well: infectious, post-infectious, autoimmune, mechanical, neoplastic. Okay, so mechanical is really the biggest one. We need to think about all of the other causes. Mechanical is going to be the biggest one in this category. So there are a whole lot of things that do this. These diagnoses are sort of fun. These are things you probably saw during residency. We see a lot of sort of mechanical related to overuse or hypermobility that can start as monoarticular. Tarsal coalition is a big one in the lower extremities. Tarsal coalition is a congenital fusion of tarsal bones that starts out as fibrous and then becomes cartilaginous and then bony over time. Patients present with decreased subtalar motion that can mimic arthritis. Compared to arthritis, tarsal coalition tends to have sort of a hard endpoint. In arthritis, you feel the resistance gradually from pain, but in tarsal coalition, it's more of a hard endpoint where you feel like the bone is preventing you from inverting the foot. X-ray can be suggestive, but diagnosis is made by CT or MRI, typically. Avascular necrosis, osteochondroses of multiple places. Perthes is the most common, but there are similar osteochondroses in other joints, including the wrist, the navicular bone of the foot. Osteochondral lesions present predominantly in the knee, but can be other places that are repetitive stress injuries, can have some effusion. Discoid lateral meniscus is an enlarged, abnormally shaped meniscus that you're born with, but that over time can start to impede motion. They're more likely to tear. These patients present with painful limited motion, sometimes with small effusions. Slipped capitofemoral epiphysis, another one that pediatricians are pretty aware of, but I've made this diagnosis occasionally, and this is one that's obviously important to get rapid surgical intervention. Infectious causes, osteomyelitis, we need to think about that. Osteomyelitis happens near the joint often. Neoplastic causes, near the joint, we think about Ewing's and osteosarcoma in a monoarticular presentation. When I teach about evaluating the patient with musculoskeletal pain and their workup, we focus a lot on history and physical. The workup beyond that, you really just need to get CBC, sed rate, x-rays. Those are the things that will prevent you from missing sarcomas, malignancy, occult fractures, etc. These are things that going through the basics before we get to a lot of fancy testing is incredibly important. And doing those things will keep you safe in terms of not missing bad diagnoses. Post-infectious typically has arthritis. It's typically polyarticular like we talked about, so this is less common. A monoarticular joint pain without arthritis is rare. Chronic non-infectious osteomyelitis, formerly called chronic recurrent multifocal osteomyelitis. I think it might even have a new name now. Part of the thought about changing the name is that some of these patients will have a one bone presentation. Often it could be near the joint. Proximal tibia is a very common location for chronic non-infectious osteomyelitis. This is a patient, so mechanical is our number one. This is a girl who has an osteochondral lesion of the femur. If you look on the medial aspect, I'm not sure if you can see my pointer, but there's a lucent round lesion. When you do this, it's important to get a view called a tunnel view. This is actually not a tunnel view. It shows up on your regular AP view, but the tunnel view actually looks at the undersurface of the femur where osteochondral lesions are most likely to occur. This patient unfortunately has JIA plus an osteochondral lesion that has made her management somewhat difficult. We've been able to control her arthritis for the most part, but she has developed this in association with softball. So x-rays are your friends. All right, polyarticular with arthritis. Think about your categories. Look at the picture on your phone. So polyarticular with arthritis is two big causes. There's post-infectious and there's autoimmune. Again, duration is your friend. Acuity of presentation really helps you distinguish these historically. Neoplastic, infectious, mechanical are all on the list, but less common. So post-infectious causes. Post-streptococcal is the most important. These are sort of the big three that I think about in post-infectious arthritis. Post-streptococcal is the most important to rule out because of its overlap with rheumatic fever, and that's a whole talk unto itself. But strep is the only really antecedent infection in reactive arthritis where you have implications for future health. beyond the joint. Most of these post-infectious arthritides will resolve within the first 6 weeks. That's a good rule of thumb, and the reason for the criteria in JIA that you need a duration of 6 weeks. But having a high threshold or a low threshold for looking for post-streptococcal or rheumatic fever is important, because this is the one that could impact their health future with risk of carditis and need for prophylaxis. You have to balance ordering of streptococcal serologies with the fact that school-age kids, about 30% of them will have positive streptococcal serologies. So history is important. You don't need history of an antecedent strep infection, but what you need is an acute arthritis, often migratory, typically polyarticular. We don't want to order strep serology in patients who've had joint pain for 2 years or joint pain without arthritis, because we will have a lot of positives that are not meaningful. The enteric organism, so the classic reactive arthritis, much more common in adults than in kids, is associated with bacterial enteric organisms, Salmonella, Shigella, Campylobacter, etc. This tends to be quite painful. It is often associated with HLA-B27, and these patients do have a risk of future more chronic arthritis. Parvovirus arthropathy is the one that can most closely mimic JIA in terms of a viral arthropathy. It can be polyarticular, it can be small and large joint. It is more likely than other post-infectious or para-infectious arthritides to last longer than 6 weeks. Some of those patients will eventually meet criteria for JIA, and can be challenging to know if this is just parvovirus infection or whether parvovirus is really the trigger for JIA. But these patients need to be followed over time until they either declare themselves as JIA or improve. Many other post-infections can cause a post-infectious arthritis, but these are the ones that are sort of unique and important in terms of how they impact our patients. Autoimmune polyarthritis, we think about JIA number 1, but this is the one where you start to get into lupus, mixed connective tissue disease, drug-induced lupus. Minocycline-induced lupus is often a relatively fun diagnosis to make in our clinic, because those patients present with a lot of arthritis and get better. It can take quite some time, but those patients can get better with stopping the medicine. Sometimes they need some steroids or disease-modifying treatment even sometimes, but will resolve over time. The most common other manifestation that minocycline-induced lupus patients get is autoimmune hepatitis, so being aware of that and looking for that is important. But those patients present with a profound polyarthritis typically. Vasculitis can present with arthritis. Often this is periarticular. Patients with vascular disease, they leak fluid from the joint, from the vessel, they leak blood from the vessel. Patients with HSP, you think about very painful, it's often gravity dependent, ankles, knees. But when you start to really feel it, it's often around the joint. It may be within the joint, but there's a big periarticular component of the swelling. And then when you think about Kawasaki's disease, there's varying levels of involvement in Kawasaki disease amongst rheumatology divisions around the country. I think we're getting more involved in general because we're using more of our medications to treat it at this point. But of the Kawasaki criteria, the most specific are swelling of the hands and feet. Okay, you think about rash, mucositis, those things are common in a lot of childhood illnesses. But when you start getting diffuse swelling of the hands and feet, you need to think about vasculitis. IBD can present with polyarthritis, sarcoidosis. So neoplastic causes leukemia and disseminated neuroblastoma are the two big ones. In every pediatric rheumatology clinic, leukemia diagnosis is probably made once a year, if not a few times a year. Excuse me. So we're going to talk about how to do that. Those patients typically present with, they can present with arthritis, but they have pain out of proportion to swelling. They have nighttime pain that's accompanied by daytime pain. They typically have elevated inflammatory markers. When we think about looking for the diagnosis of leukemia, patients who come to our clinic typically don't have blasts in their peripheral smear, or somebody else makes the diagnosis. So we look for other evidence. Often they have relative thrombocytopenia. So when you think about platelets are an acute phase reactant. If a patient has fever and or inflammatory reaction that lasts longer than a week, you should see the platelets going up. If you don't see them going up, you should think about a marrow-infiltrated process. So platelets in the 200s with a SED rate of 100 and 2 weeks of joint pain, that should concern you. What else? Disseminated neuroblastoma is rarer. It's young kids. This can invade the bones, obviously. Characteristics of the pain is important. And we'll talk about a little bit more in the next section about bone pain. Polyarthritis, there are a relatively small number of infections that cause a polyarthritis. You need to think about the Neisseria species. So we talked a little bit before about gonococcal arthritis. Neisseria meningitidis in the same family rarely can present chronically with an arthritis, typically accompanied by a vasculitic rash. This can mimic HSP. We saw this once at our clinic. HSP patients with fever need a blood culture. That's the lesson I learned from that interaction. So in our part of the country, Rocky Mountain spotted fever can present with the polyarthritis. That is a vasculitis. They get a vasculitic rash. Another infection is the Streptobacillus monoformis. This is rat bite fever. These patients look very similar to a disseminated gonococcus in patients who are either younger or not sexually active. This is high on the differential. They present with a febrile polyarthritis. Often they have a vasculitic rash. Typically, you can grow this out of the joint, but you have to use special culture techniques. And typically, the diagnosis is made by history, hopefully, from exposure to rat or other rodents. Mechanical and polyarthritis, again, this is not arthritis, but they can present with painful limited motion. Any of the things we talked about mechanically that can be unilateral, there's a certain percentage that can be bilateral. So having an awareness for that is important. All right, so migratory arthritis. You hear that term thrown around a lot. Migratory arthritis is not 6 months of pain. Some days it's my wrists, some days it's my knees, some days it's all of them. Migratory arthritis is very distinctive. It typically happens every 24 to 72 hours. It is typically very NSAID responsive. It's typically large joint. The historical question that I like to ask, is there any, if a patient presents you with a polyarthritis, are there any places that used to be swollen and painful that are not anymore? And when that happens, that is not typically leukemia. That is not typically, even though that's on the list, it's officially on the list. Leukemia is more of an additive arthritis where you're just adding joints. Joints to get better, that is almost always a post-infectious process. JIA doesn't do that, not in a short time period at least. HSP migrates places, vasculitis migrates places. Lyme can migrate, but it tends to be more dramatic sort of waxing and waning of knee arthritis. IBD can be migratory. It's rare that a migratory arthritis becomes a chronic rheumatic disease. So arthritis, which has sudden acute onset, typically has sudden resolution. Now, the patient might not think this, other doctors might not think this. Sudden is in context of rheumatologists. We think about long duration. We think about 6 weeks as within less than 6 weeks, most of these migratory arthritides are going to improve and resolve. So leukemia, it's important to obviously make this diagnosis. It's also important, we use a lot less steroids these days, which is great. But when you have a patient with a febrile arthritis, one of the important things is before you start steroids, you want to rule out malignancy. And this was much more important before we had biologics. Obviously, you would not ideally start a biologic either in leukemia. But steroids partially treat the leukemia. They delay the diagnosis. They change the prognosis and even the treatment arm that the patient ends up being on in terms of what drugs they're going to receive. So when I was first starting in fellowship, there was this teaching that in some places that nobody with systemic JIA should start steroids without a bone marrow. I don't think anybody really does that anymore, but you have to go through the process of thinking about this. So ALL is by far the most common. These patients have nighttime pain accompanied by daytime pain. Patients with pain at night are going to be your least sick patients and your sickest patients. If they have isolated night pain and are perfect during the day, that's unlikely to be a bad diagnosis like leukemia. But patients who have night pain accompanied by daytime pain, that should arouse your suspicions and make you want to fully evaluate and have a high index of suspicion of malignancy and other significant illnesses. They have pain out of proportion to objective findings, so they have they have marrow infiltration. This is bone pain. Although they can get some effusion, it's not usually a large effusion. They may have metaphyseal tenderness. You look for lymphocyte predominance on CBC and what we talked about, the relative thrombocytopenia. LDH is an important marker as well. There's a recent study that looked at this and looked at patients with fever and or elevated inflammatory markers in bone pain or joint pain and tried to distinguish, which of these patients ended up having malignancy. The patients with hepatosplenomegaly, lymphadenopathy, and non-articular bone pain, regardless of their other findings, have a high rate of having leukemia. Hepatosplenomegaly and lymphadenopathy can be part of the presentation of systemic JIA, although I have to say I think I'm seeing that less recently. I think because we are quicker to diagnose systemic JIA, there's more awareness. We don't make the patient have arthritis for 6 weeks if they're a systemic. We're seeing less hepatosplenomegaly and lymphadenopathy at presentation and during the course of the disease. Anorexia and weight loss are obviously concerning findings. Platelets less than 300,000. And these are in patients who have, in this study, it was a month of fever and bone pain. I think that's too long. I think we ought to be looking at this at 1 to 2 weeks, depending on the characteristics of their pain and their evaluation. Polyarticular no arthritis. This is our last category. So think about categories of etiology: infectious, post-infectious, autoimmune, mechanical, neoplastic. Okay, so mechanical is the biggest one here. This is also a group that are going to be the sickest and the least sick. So it's important to look at, warning signs in these patients. But mechanical is the most common. Sick versus not sick is important. Hypermobility is going to be a big one in your clinic. We see a lot of patients who are older who have hypomobility. They may have really tight hamstrings or Achilles or other things that predispose them to pain. We talked about any of the things that can be unilateral in terms of osteochondroses, et cetera, can be bilateral. And polyarticular without arthritis is where you get into amplified musculoskeletal pain and fibromyalgia. Neoplastic causes may or may not have arthritis. Again, getting into the sick versus non-sick patients is important. Bone pain should always worry you. Post-infectious, with rheumatic fever, you can have arthralgia without arthritis. That's relatively uncommon. Often you're making the diagnosis of arthritis in rheumatic fever somewhat retrospectively, but by history when it's migrating. But patients who tell you, families who tell you, for a day on Tuesday, she didn't move her left arm and kept it sort of to her side with her elbow bent. That's probably elbow arthritis. Autoimmune, chronic non-infectious osteomyelitis, formerly CRMO, typically is multiple bones. History, radiography, sometimes advanced imaging, sometimes CRMO will be not seen on x-rays, so advanced imaging with MRI can be helpful. And then arthralgia associated with viral infection can be polyarticular without arthritis. So in history, the biggest thing we talked about was duration and acuity of presentation. We've talked about most all of these things. JIA tends to present with swelling and limitation of motion out of proportion to pain. So it's very common that patients will present and the family will say, I just noticed that her knee was huge and she'd never complained of it. I have a family who was playing cards and they noticed that their daughter's knuckles were swollen. We have patients who the PE teacher recognizes they can't put their palm flat on the ground when they're doing push-ups, but are doing push-ups on their fists without complaints. So patients with JIA tend to have, not all, but they tend to have swelling and limitation of motion out of proportion to pain. So the rules of growing pain, thinking of patients who have night pains, how do we determine if they're benign or they're signifying a more serious underlying illness? So I think these rules are helpful. They should not be present during the day or especially upon waking. There's no limping. They're not limited in physical activity. It's symmetrical, lower extremity. They have a normal physical examination, although hypermobility might be present and is often present. They're systemically well. They have normal gross motor milestones, and they're in the age range of 3 to 11 years. So, younger patients and older patients, you should be suspicious. People out in the community can see a patient like this and not order blood work and x-rays. And we might feel good about that on occasion, but generally when a patient has, quote, growing pains that are bad enough to get them to a rheumatologist, I think the CBC, an inflammatory marker, and x-rays is appropriate. But these can help you with sort of how worried should you be about this patient. Review systems, you guys are all going to be really good at this. you can get hints from all parts of the body about our diseases. Okay. Other things you look at: physical examination. We talked about the definition of arthritis. Swelling, or in the absence of swelling, limitation of motion accompanied by pain with motion, tenderness, or warmth. Septic arthritis. So you have that monoarticular patient. We typically think about septic arthritis having no painless motion, so they hold it very rigidly, and any motion is resisted. JIA patients tend to have restricted motion, but they have an arc within which they have relatively painless motion. So at the ends of motion, they start to get pain and resistance. Determining duration. So history is important. Sometimes a patient will show up with a huge knee. The family just saw it. They don't know how long it's been there. You want to get some idea to help your decision-making and diagnostic process. So limb length is important, especially in the lower extremities, because you have growth plates about the knee. The knee is the one that affects limb length the most. The joint is going to tend to grow longer on that side because of increased blood flow, angiogenesis, and you see that relatively quickly. So that's a limb length discrepancy will tell you, at that age, we think about this in young growing patients who are growing about 5 centimeters a year. So if you see a centimeter limb length discrepancy, I think about that as being probably a couple months minimum. That helps you in terms of duration. If you have really poorly controlled arthritis, occasionally see a patient who's had long-term poorly controlled arthritis. That limb will actually end up being smaller because it will have gone through the whole maturation process and had physeal closure early, while the other limb is still growing. Hopefully that's very rare in our current era. Atrophy. So, when you get casted, you get atrophy relatively very quickly, within days to a week. And when you're just guarding a joint and you're actually still putting weight on it, atrophy tells you that it's been going on for a while. Contracture. So we talked about there's the difference between the rigid guarding that patients with septic arthritis get versus pain at the ends of motion. So JIA patients tend to protect their joints at the ends of motion, and over time they get a joint contracture and they get shortening of the muscles, and that feels a little bit different. So leg length discrepancy. This is the classic oligoarticular JIA presentation. This is on one of the rheumatology picture collections, but it was a boy, so I didn't show him because he's supposed to be a girl. This is the early onset oligoarticular. That's about 5-to-1 female to male ratio. Predominantly the knee. So you see the knee is held contracted. It's a little bit longer, so they're holding it sort of out to the side. When these patients are treated, you want to give a shoe lift to the other side to force them to straighten the right knee in this case more. Hypermobility, something you'll see often in your clinic. Knowing the Biden criteria are important. Patients with hypermobility tend to present late toddlerhood to school age. I don't really apply the Biden criteria until they're 5 years old, just because of the flexibility that is present in babies and toddlers. Patients with hypermobility tend to have pain at the end of the day. They may have night pain. They can be helped with physical therapy. They are more prone to amplified musculoskeletal pain as well. So we talked about, I think that the most helpful is CBC with differential inflammatory markers and plain films as your sort of baseline for anybody with joint pain. We're going to talk about some cases. We're going to do these relatively fast because you all can't talk, and we need some time for questions. So this is a 4-year-old Caucasian female with 2-week history of knee pain and morning stiffness. She had a sore throat 2 weeks ago. Rapid strep and throat culture were negative. She was treated with amoxicillin. This patient is afebrile. She has, this is the exam from the resident team. She has a left knee with moderate fusion and warmth and refuses to fully extend her knee. So this patient is a monoarticular with arthritis. So we think about infectious and autoimmune are our top ones. She's afebrile, and then she becomes febrile. She has a high SED rate, so our suspicion of infectious arthritis goes up. Gets an arthrocentesis, which is very bland, really doesn't look like infection. So then rheumatology is called to see this patient, and we find sort of a more chronic arthritis affecting multiple joints. So the lesson is examine all the joints. This patient had JIA, probably had a flare of her knee arthritis in response to infection. Okay, case 2, this is an 11-year-old female, knee injury during basketball season. Had minimal limitation of extension exam, a small knee effusion, had quadriceps atrophy, had negative McMurray sign, looking for a meniscal pathology. Labs are reassuring with the exception of a positive ANA test. Had a normal X-ray. Had an outside MRI, was read as a fusion synovial enhancement with no internal derangement. So we diagnosed this patient with presumptive JIA. She had persistent swelling, one knee, evidence of chronicity, had a positive ANA, which is not diagnostic but suggestive. We treated her with NSAIDs. We did a joint aspiration and steroid injection at the same time. She did not have much improvement. We did a repeat MRI. She had a discoid lateral meniscus. So lessons from this patient: don't always trust the outside MRI read. ANA does not make the diagnosis of JIA. Those are the 2 big lessons. Case 3, this is an 8-year-old Vietnamese female. She had bilateral knee pain while on vacation in Chicago. She had fever and emesis and had knee pain and swelling. So thinking about this patient, this is a polyarticular with arthritis patient. Our category is, top categories are post-infectious or autoimmune. We have some acuity, so we need to think about post-infectious causes. And we have fever as well. They're giving naproxen. She's had an ankle involved. She's having some migration. She comes to the ER breathing fast and deep and had both aortic and mitral regurgitation, very high ASO, and had rheumatic fever. So in patients with polyarticular arthritis, relatively acute, migratory, ruling out antecedent strep is the most important part of the presentation, of your evaluation. Okay, this is a 12-year-old female with 3 weeks of joint pain, nasal congestion, some epistaxis, both feet with pain and swelling of the dorsum, and non-blanching papules on the dorsum of the hand. So there are a few, and thinking about this patient has polyarticular arthritis. So you're in the category of infectious, autoimmune and post-infectious. the important lessons in this patient, looking at the whole patient, you have warning signs of vasculitis in this patient. So diffuse swelling of the dorsum of the foot, non-blanching rash, epistaxis, all concerning for possible vasculitis. This patient has fever, oral ulcerations, pulmonary nodule, urinalysis. This patient has an ankylosing. Case 5, this is a 21-month-old female who presents with limp. She favors her right lower extremity, but she's ambulatory. She's afebrile. Physical examination is normal. X-rays are negative. They did X-rays of basically the whole leg, and these were negative. The child was looking well. She was sent home from the ER. She got somewhat better at home. 1 month later, she had limp and was favoring the other leg. Still a normal physical exam. She gets labs, very high SED rate. So this is a patient who's polyarticular, no arthritis. This is the sickest or the least sick group. This patient falls in the most sick group. This patient ended up having disseminated neuroblastoma. So, the retrospective scope is always more accurate and easy to use. I think that this patient, at the first evaluation, blood work probably would have increased suspicion. Presence of limp is concerning. Presence of pain without objective arthritis is concerning for bone pain, particularly in a young patient. Okay. Take-home messages. History and physical are important. You guys know that because you went into rheumatology. We can classify these things. I hope the classification criteria or schema I used was helpful. Duration is very important. Being completed in review assessments, getting really good at the joint exam, and being selective but careful in ordering of ancillary studies. And I think we will progress to the question and answer session.
Thank you, Dr. Graham. That was an excellent talk on joint pain. So just as a reminder, there's a Q&A button that y'all can use to submit your questions. But for our first question, Dr. Graham, as a first-year fellow, what do you recommend as general advice when the fellows are fielding calls from like the ER or the inpatient team? They can't see the patient. They can't determine for sure if there's arthritis or not. How do you recommend that they go about thinking about those patients?
Yeah, that's a big question. I think that an easy answer is if you're getting called, we generally need to figure out ways to see the patient. And, in our institution, if rheumatology gets called, they generally want us to see the patient. But, I think they're the same principles. I think, if it's the middle of the night, you're not coming in, et cetera, doing the basics. You want to order an ANA and a rheumatoid factor and not a CBC. And you want to examine the joints. You want to think about duration and making sure they look at sort of the whole picture in terms of other clues from the history and the exam.
So I have another question, Dr. Graham. So you alluded to this in some of the cases you presented, but how do you really factor in, especially in young children, sort of this reported history of trauma that a parent may tell us when they're giving the story?
Right, that's a really important one. So very frequently in JIA, you will have a history of trauma at the time that the parents notice the knee or the joint that's affected. And it's probably true for a lot of other entities as well. And we're obviously never there when the trauma happens. So that can be challenging. I actually had a family recently where the father was the basketball coach, and she'd had this trauma, and he videotapes all the games, so we were able to watch in detail the injury, slow-mo, back and forward, just like ESPN. That's the only instance I've ever been able to do that. Generally, what I think is that probably the inflammation was there and the injury brought attention to it. You definitely we're suspicious by nature as rheumatologists, but I guess you just have to really take that with a grain of salt, the trauma history almost always. And I think that's true for other things as well. Families, young kids, especially toddlers, they fall, they have injuries, and families are quick, appropriately, to attribute some pain to a fall. And you just need to be, not hang your hat on that as you're evaluating the patient.
All right, another question from the audience. On some of the cases, you described patients with bilateral knee pain, and you're classifying them as polyarthritis. For the sake of the differential, do you pool the oligos with the polys, and does the location of the arthritis matter?
Ooh, okay. So in the presentation, the one who had polyarticular with arthritis, it was relatively acute, the one girl who ended up having rheumatic fever. Classification, oligo versus poly, is sort of a little bit beyond the scope of this talk. When I'm saying polyarticular, I'm talking about 2 or more joints. Okay, I'm talking about, I think that now I understand where the question is coming from. We're not talking about patients with JIA. We're talking about a patient who presents with 1 joint or with 2 or more joints. So I think that's where the question is coming from. When I'm thinking about a differential diagnosis, having 1 joint versus 2 or more joints is how I think. When I start narrowing into JIA, then you use oligoarticular as 4 or fewer, and the monoarticular patients would fit within that.
All right, and we have one final question before we close, and I will say that this is a question that's going to be on the mind of all of our incoming fellows, and so I encourage all the program directors to have conversations about this. But this question just relates to, in light of the fact that we're dealing with this pandemic of COVID, how different do you feel that our fellowship training is going to look compared to prior years?
Oh boy.
That's a tough.
This was not part of the learning objectives. But,
yes, no, I know.
but it's important. So, yeah, I think that we're all in our clinics trying to figure out the balance of risk and benefit in terms of what patients need to be seen in person. I've been a huge proponent of feeling the joints, and I still am. That's going to be a huge part of your assessment. I think that we are seeing patients by telemedicine that I thought we wouldn't see. But we're always trying to find a balance of risk-benefit in terms of what's happening in your community. So in terms of your training, I think you need to really soak up every opportunity you can for physical examination. It's going to be even more important if there are times when that is limited. If the pandemic gets worse in certain areas and we're restricted to telemedicine again, we, in the past few months, we've limited our number of times a week that each attending comes, but we're trying to make sure we incorporate fellows. We've kept our nurse practitioners predominantly at home. Training is going to be a huge part of the pandemic because you have only 3 years. I don't think we're planning on extending training, so maximizing your time in clinic. Any thoughts from Tracy or Elizabeth are welcome as well about that.
No, I agree. And again, I think it's really been important for this to be an ongoing conversation between the program directors and the fellows, as to, because this will be a different experience. So it's actually, it is our time, 10:30 to close. And so I just, again, want to thank Dr. Graham, for providing this excellent lecture to launch this practicum. And we thank all the participants for joining us. And then we look forward to seeing you with the next lecture. And I wish everyone a wonderful day. Take care. All right.
Thank you,
Bye-bye.
everyone.